Good evening, doctors. Welcome to the second episode of the audible explanation of pathways of the pulp. Today's episode is going to be about lesions that mimic endodontic pathoses, which means that they are pathoses that have the appearance of an endodontic problem, endodontic periapical problem, but in reality they're not the same thing. So we will talk about how to diagnose and how to know where to leave, to not do anything, and when surgery is recommended, and where the problem can be solved by removing the irritant, whether it is by an endodontic procedure or with extraction. So let's dive in it. We must know that radiographic findings associated with non-inflammatory pathologies can very closely mimic the presentation of the more common periapical cyst or periapical granuloma. So, there is no way to definitely determine the clinical importance of lesion based on radiographic features alone. For that, medical history, dental history, and pulp testing can yield a differential diagnosis. Let's see how a normal radio periapical inflammatory looks like. Here we have a molar that is necrotic, and there's a widening in the PDL with asymptomatic apical periodontist in the mesial root. So we did the doctor did an endodontic treatment, and there was healing after 6 months. This is another case that has the same thing, and that gave out the conclusion that this periapical lesion was a bacterial and inflammatory one. Let's see what are the multilocular radiolucency. The presentation of periapical inflammatory disease should be radiographically unilocular and confirmed with lack of responsive to pulp testing. But if a multilocular radiolucency is identified and we have an extent of growth in the lesion, then the differential diagnosis of multilocular radiolucency must be taken. What are the most common radiolucency that are multilocular? We have the odontogenic keratocyst, the Ameloblastoma, and the central giant cell lesion. We will talk about them now. Odontogenic keratocyst is a developmental cyst. It occurs, it has a neoplasm with Odontogenic keratocyst is a developmental cyst. It has substantial growth potential and recurrence risk. It has a thin, non-inflamed, stratified squamous epithelium cyst. These cells can be easily dislodged from the underlying connective tissue during surgical treatment. This is the reason why it has the increasing likelihood for recurrence, which can be of 30% of rate, and it can occur more than 5 years after the original surgical intervention. So long-term follow-up is mandatory. For the radiographic features of the odontogenic keratocyst, it is usually associated with an impacted tooth. For 40% of the cases, it should not be confused with a lesion of an endodontic origin due to its location surrounding the crown. when it is unilocular. Sometimes it can be unilocular and it can be indistinguishable um, from the lesion of an endodontic origin. We had this case uh, that the radiolucency is surrounding the right premolar region. We can see that the obvious margin of it. It was an odontogenic keratocyte. We can see here another case in the right side of the mandible. The cyst is here. It is associated with the second molar. After extraction and follow-up after 3 years, no recurrence has occurred. We said that this cyst is associated with the non-eruptive tooth. So we have here a case of a 10-year-old female with a mixed dentition. She was taking these panoramic images for an orthodontic reasons. When this radiolucency was observed, the treatment was unroofing the cyst without the removal of the entire lesion, and a panoramic image after 2 years was taken, showing no evidence of recurrence, and this periapical image after 6 years of the surgery also showed that there was no recurrence. Now let's talk about the ameloblastoma. Ameloblastoma is the most common odontogenic tumor. These benign tumors are slow-growing but can become large and disfiguring if left untreated. Ameloblastomas will often infiltrate normal bone, resulting in extension beyond radiographic margins and higher recurrence rates. Marginal recession is the most common treatment, but recurrence rates are of 50%. So, surgeons are recommended to take 1 to 2 centimeters recession margins to avoid the recurrence. However, when the tumor presents near vital structures, a resection may not be possible, and the resulting curettage is associated with a recurrence rate that ranges from 50% to 90%. So, follow-up is mandatory. As for the radiographic features, we have expansion of the cortical plate, and when ameloblastoma becomes big, it can cause resorption of adjacent teeth. We can see here the destruction of the buccal cortical plate when the lesion was in the mandibular lateral incisors. Central giant cell lesion. It has the same as the odontogenic keratocyte and ameloblastomas, that they are often found in the mandible, and they are multilocular radiolucency, but can be unilocular when they are small in size. Surgical extraction, surgical treatment is recommended. We can see here the radiolucency cannot be differentiated from other multilocular lesions without a biopsy. So, the left mandibular premolars and canine had non-surgical endodontic treatment prior to removal of the central giant cell lesion. But when the removal has happened, the blood supply of these tooth was compromised. So the root canal treatment was recommended for this tooth. After 18th month recalled with evidence of increased bone density but not complete healing. As for the radiographic features of the giant cell of the central giant cell lesion, when it is non-aggressive, it should not cause perforation of the cortical plate or resorption of the roots. But the aggressive version of it may result in perforation of the cortical plate, resorption of the tooth, and parasthesia, and extension into the soft tissues following the perforation. We finished the three most common lesions that are multilocular radiolucency. We must know that when they are smaller lesions in the periapical region, they cannot be distinguished from the periapical cyst, and they have the same look. The three of them are the same. We can differentiate between them when they are have an aggressive attitude, or they reach high, large sizes. The radiopacities in the periapical region. Endodontic lesions of inflammatory origin must often present as radiolucent lesions with no indication of radiopacity. As a result, if any evidence of radiopacity is identified, suspicion of a non-inflammatory etiology should be elevated, especially if unlimited restorative history is present or pulp testing is conclusive. An exception to this rule are the two inflammatory radiopacities lesions, which are the condensing osteitis and the sinusitis, the maxillary sinusitis of endodontic origin. Let's talk about each one of them. The condensing osteitis is an area of bone sclerosis in the periapical region that results from an inflammatory stimulus secondary to chronic pulpal inflammation or necrosis. It is most commonly diagnosed in children and young adults, but it can occur in older individuals. Compact bone replaces the fatty marrow, and there are variable levels of fibrous consistent with an osteoblastic response to a low-grade stimulus. Treatment is focused on removal of the inflammatory stimulus, and 85% of these lesions resolve to some extent following root canal treatment. It is usually present in the premolar and molar regions in the mandible. Here we can see a widening of the PDL, radiodense at the apex. We can see that it is associated with the premolar in the mandible. So, taking these signs, we came to a conclusion that it was a condensing osteitis. It is usually associated with the caries, tooth that has caries or heavily restored tooth. The maxillary sinusitis of endodontic origin. It is an inflammatory disease of microbial origin caused by a necrotic pulp or a root canal treated tooth. When we know that it causes 10% of sinusitis cases. When we know that the space between when we know that the distance from the mesiobuccal root of the maxillary second molars to the sinus floor is less than 1 millimeter, and 40% of maxillary molars have a root that protrudes into the sinus, so infection is common. This endodontic infection can cause bone destruction, leading to a communication through the floor to of the sinus. This communication can result in the accumulation of inflammatory mediators, elevating the sinus lining or triggering an osteoblastic reaction. So, the maxillary sinusitis of endodontic origin is a result from a necrotic pulp or a tooth with post-treatment disease. There will be no thermal sensitivity, and it can be associated with headache, facial pain, unilateral nasal obstruction, postnasal drip, and nasal discharge are clues to the presence of this disease. The treatment involves the elimination of the bacterial etiology with root canal treatment, endodontic surgery, or extraction. Here we can see the protrusion that the tooth has made inside the sinus because of the infection that happened in the mesial root. The sinus can react by building and by triggering the osteoblastic cells and make a bony barrier, or it can be displaced superiorly into the sinus and look like a dome shaped. Like this case, we can see the elevation of the sinus floor due to the inflammation of the root canal. This tooth was non-responsive to thermal testing. It was painful to percussion, indicating an periradicular infection. The CBCT revealed a homogeneous dome-shaped elevation into the maxillary sinus. But there are some radiolucency infections that are not known the cause of them. They are not inflammatory, but their presence needs no treatment, like ldiopathic osteosclerosis. It happens mostly for the adolescents when they are in the growing phase, and they may remain unchanged or continue to enlarge after they reach to their full development. The diagnosis of it is based on clinical presentation of the lesion, the pulp testing of the teeth area, and restorative history. If any of the clinical findings are suspicious, a biopsy could be done, but typically the diagnosis can be made based on the clinical characteristics and no treatment is indicated. As for the radiographic features, it has so similar to the condensing osteitis. It is most commonly located in the first molar region, but the teeth are usually vital and response to the stimulus. Here we have a case for a 15-year-old female, and we can see that the lesion is not invasive. It has no indication of any root resorption. What about odontoma? Odontoma, is also a radiolucent lesion or structure abnormality that can be found in the jaw. It only needs extraction, and its surgical removal has an excellent prognosis. It has two types, a compound odontomas and a complex. The compound resembles a teeth structure in shape and in component. As for the complex, it lacks the shape of normal teeth, but we can see some tooth structure like the dentin, cementum, and can be differentiated in them. So odontoma is identified as it is an abnormality that is composed of tissues found in normal teeth, including enamel, dentin, and variable amounts of pulp and cementum. So all the components of the tooth can be seen. It is actually associated with a non-eruptive tooth, and in the maxillary region or the molar region. We can see here the high density of a tooth-like structures. Only extraction of these abnormalities are enough for having a normal eruption and a healthy tooth. We can see here the complex odontoma here with high density globular mass near the crown of maxillary first molar. So they are saying that the complex odontoma is associated with the molar region, and the compound odontoma is associated with the maxillary centrals and laterals for the most cases. Let's finish up the radiolucency diseases by talking about a syndrome, not a syndrome, but a disease that has a family history, which is called the Paget disease of bone. It is a metabolic bone disorder. It has an abnormal deposition and resorption of bone because there is a defect in the osteoclast and the osteoblast, resulting in a thickened, enlarged, and weakened bone. And the specific etiology is not known, but as we said, it has a family history of it. It has a slow progressive feature. When it is asymptomatic with a limited involvement, it requires no treatment. It is usually associated with other bones in the body, like the pelvis, femur, lumbar, the vertebrae, and the skull. There is a 20% of cases that involve the jaws as well. It is usually in the maxilla, twice likely to be affected compared to the mandible. Here we can see the left and right of the mandible have different radiolucency, that is different radiolucency and radiopacities. They are so, and we can see the significant root resorption of the tooth. Now we finished the radiopacities bone, radiopacities and lesions. We have seen that some of them are inflammatory and need an endodontic or extraction, and some of them are non-inflammatory, like we said, the odontoma, and that need surgical extraction, extrusion. And some of them, like the idiopathic osteosclerosis, needs no treatment. So specific and accurate diagnosis is highly recommended to know which treatment is the most suitable. Now let's talk about the most common multifocal radiolucency that mimic the lesion of an endodontic origin. It is the most common radiolucency lesion in the apical area that actually needs no treatment, and treatment of and usually an endodontic treatment is is applied, which is not necessary when there is a lack of an accurate diagnosis for this lesion. So let's know how it is usually how does it usually appear. Cementoma is the replacement of bone with fibrous and mineralized tissue. The teeth are usually asymptomatic. The teeth are sound. They have no necrotic pulp in it, and they are unrestored and should respond normally to pulp testing. Here we have a case that the maxillary tooth in the anterior mandible, they had no history of trauma. They were asymptomatic, and they responded to both cold and electric pulp testing. So no treatment was indicated, and it was diagnosed as cementoma. On the contrary, for this lesion, a biopsy was taken, and in this case here, taking the biopsy to know what is the lesion caused necrosis on those teeth and demanded a root canal treatment. Even a sinus tract has developed. The florid cementoosseous dysplasia is also something that does not need any treatment. It is different radiolucency, and that affects both sides of the mandible, and it can also affect the maxillary part too. Now, before we go to the more invasive lesions, let's take a quick note on when do we do a biopsy. After doing the treatment, whether it is an endo for a vital pulp or a necrotic, and we see that doing the follow-up there was no cure or resolving of the symptoms, or the biopsy or the radiolucent area was increasing, not decreasing, or there was root resorption, the tooth was mobile, the bone is expanding, and there is a perforation of the cortical plates. In these situations, a biopsy must be taken. Let's talk about more invasive lesions. The non-Hodgkin lymphoma represents a group of malignancies that most often arise in the lymph nodes. They can originate from either B lymphocytes or T lymphocytes, and they are associated with patients with immunologic abnormalities that have several viruses have been implicated in the pathogenesis. These lesions are slow growing, and they are associated with a group of lymph nodes. Usually chemotherapy is the common treatment, and if the patient refused any treatment, a survival rate of 8 to 10 years is something common. Here we have, take note to the symptoms. We have numbness, swelling, the tooth had radiolucency that is associated with the four of them. Even the tooth had limited restorations, and some of them had no restorations at all. They were responded normally to pulp testing. These signs made us think that there is something more than a normal radiolucency. Non-inflammatory etiology, So a biopsy has revealed that it was, unfortunately, a lymphoma. We can see here the resorption that invasive lesions have, and perforated of the buccal and palatal cortical plates are also a sign that we must take notice of. Sign of aggressive. Let's talk about something now. When do throat cysts heal after doing an endodontic procedure? Actually, if the cyst is true, which means that it is lined by epithelium in all of it, and it lost the connection between it and the root canal treatment, then doing the endo does not resolve the true cyst, and it will remain only by surgical extraction. By surgical removal of it will be mandatory. But if the pocket cyst, which are in that has direct contact with the root canal system, they have greater likelihood for healing following an endodontic treatment. So, after doing your root canal treatment, having a follow-up to see that if the cyst, 3 months of follow-up is recommended to see if the cyst is shrinking in size or it is at the same size, to know to differentiate between the type of the cyst that is present, and to take the proper decision of treatment. What about lateral radicular cysts, which are cysts associated with lateral canals of a tooth? Here we have a case that a sinus tract was a 𝐏𝐞𝐬𝐢𝐴 was inserted inside the sinus tract to see the source of infection, and it was pointing to the second premolar. After the root canal was done, we can see that there were lateral canals, and after 6 months of follow-up, we had a complete healing. Here, the author is showing us that radiolucency between these are so similar in the shape, but when doing the biopsy, they were so different. The first one here was lateral periodontal cyst, but here it was a odontogenic keratocyte. So he came to a conclusion that when they're in small sizes, they cannot be distinguished from radiographically. There he says lateral radicular cyst and ameloblastomas, odontogenic keratocytes, can exhibit identical radiographic appearance in the mandibular, canine, and premolar areas. So, taking other signs for having the final diagnostic result is important, not only relying on the radiographic images. We finalize things up by talking about one of the most common cysts appearing in the maxillary area, which is the Nasopalatine duct cyst. It actually has an excellent prognosis following the surgical removal. It is usually located in the midline of the centrals, going to the laterals a bit. They are the most common non-odontogenic cysts in the jaws. They are often diagnosed after a traumatic injury. Let's take this as an example, the tooth was asymptomatic and no history of trauma, so it can be associated with trauma and can be not. It responded to both cold and electric pulp testing. A biopsy revealed that it was a nasopalatal duct cyst, and it has the rounded radiolucency in the midline. Let's summarize things up. A multilocular radiolucency should not be the result of a necrotic pulp. The presence of calcification suggests a higher likelihood for a non-pulpal etiology, except for the two lesions that we talked about, that they were the condensing osteitis and the sinusitis of endodontic origin. The last thing is rapid cortical expansion or perforation of the cortical plate, extensive tooth mobility, and irregular root resorption. All of these signs suggest a more ominous differential diagnosis. Now let's read with each other the summary of this. What are the signs that suggest periapical granuloma or periapical cyst? Tooth is necrotic and shows no response to pulp tests. Radiolucency is unilocular and limited in apex area. Wide deep lesion or previous endodontic treatment. No root resorption or cortical bone perforation. What are the signs that suggest non-inflammatory lesions? Multifollicular radiolucency, radioopacity lesion, tooth response to vital tests. Lesions does not heal after 3 months of treatment. What are the signs that suggest invasive lesions? Tooth respond to vital tests and cannot respond. Cortical bone perforation, buccal plate destruction, tooth mobility, numbness in area, multi-radiolucency around tooth that are not necrotic or have caries. Let's talk about multilocular radiolucency. The most three common are the odontogenic keratocyst, Ameloblastoma, central giant cell lesion. The three lesions are more common in the mandibular area rather than the maxilla, especially mandibular premolars and molars. The lesions are multi-radiolucent with defined borders that covers multiple teeth, or it can be unilocular and associated with single tooth. Recurrence may happen after surgical excision in varying proportions, either because of the infiltration of cells within the surrounding tissues or because of the ease of separation of cells from the mother lesion during excision. The shape of the lesion when it is single includes part of the tooth and is not limited to the apex only. These lesions may be associated with non-erupting teeth, in particular the odontogenic keratocyst. Treatment is surgical excision with safety edges to 1 to 2 centimeters with follow-up because of the possibility of recurrence during the 5 years following surgery. Radiopacities in the periapical region. Incorrect diagnosis of radiopacity, root lesions on X-rays, lead to unnecessary endodontic treatment and sometimes causes taking an extract to investigate the nature of the lesion to damage the blood supply of the teeth and thus make them necrotic. Therefore, attention to clinical and radiographic signs and follow-up is important. Condensing osteitis, it is that pulpitis may stimulate osteoblast cells and lead to bone thickening in the periapical region to include the apex and part of the root surface. It is usually associated with a widely treated tooth or necrotic tooth and is especially in the premolars and lower molars. The treatment is to remove the irritating factor either with an endodontic treatment or by extracting the tooth. Maxillary sinusitis of endodontic origin. It is an inflammation of the maxillary sinus as a result of the apical contact between a necrotic tooth containing a lesion and the base of the sinus. The sinus reacts by floor thickening due to bone deposition, or the floor of the sinus rises and forms a dome. The upper premolar and the upper first and second molars that suffer from pulpal necrosis are accompanied by headache, facial pain, and nasal congestion from the side of the inflammation, or some nasal secretions may happen. Lesions that need no treatment are cementoma, occurs as a result of the replacement of bone tissue with fibrous tissue. The tooth is vital and responds to vital tests with no history of previous trauma. An inaccurate diagnosis of the lesion exposed the tooth to an endodontic treatment that is not required. The 𝐏𝐶OD, it includes both sides of the jaw and may include all four segments. The teeth responds to pulp tests and presents radiographically as mixed, translucent, and opaque lesions. No treatment is needed. Final two questions. When do we need to take biopsy? When the symptoms do not go away after endodontic procedure, or the lesion has not healed, or there is expansion in the bone, resorption in the tooth, and movement in the teeth, and perforation in the cortical bone. Do radicular cysts resolve after endodontic treatment? When the cyst is real and the epithelium is lining the entire lesion, there is no contact between the cyst and the root. It does not heal after endodontic treatment, but if the cyst is in contact with the pulp, it can heal, and a period of 3 months to follow up the situation after endodontic treatment to notice any improvement is sufficient to determine whether surgical intervention is required.